Good morning, everyone. So thank you, Kathy, for the invitation to speak to you guys as a group this morning. I have never been invited to give a keynote presentation before, and so at first I thought, oh, what am I going to talk about? But I've been told that I like to talk a lot, and I definitely like to talk about data, so I thought, well, here's an opportunity to impart a little bit of my, I don't know if I call it wisdom, but my experience, and hopefully maybe inspire some of you a little bit, or at least, raise some questions, which, happy to talk about later as we move on. So thank you, Kathy. I also want to, thank Michael Hayes, who was the one who reached out to me originally when I moved to Victoria about a year and a half ago, and then to Betty, who brought me into the fold as a practicum supervisor, which has been a very rewarding and humbling experience, and thank you to all of you for the work that you've put in, both throughout your course and through your practicum. So I don't know, Matthew, where are you hiding? But the back corner, so most recently Matthew, who supervised for the last term. So disclaimer, the opinions expressed in this talk are my own and do not necessarily reflect the views of my employer, although I hope that some of them do. So first I just wanted to give you a little bit of background as to how I ended up, being someone who dreams about data, as I'm sure most of you in academia can relate to, and to have a passion and an interest in population health and population health data. So a bit about me and where I come from. So this is me and my parents many moons ago. Due to the magic of Ancestry.ca, or Ancestry DNA now, I can say exactly where I came from. And it was interesting to note that on my father's side, 98% English from a very specific location. And on my mother's side, mostly English and Scottish, Eastern European, but what was interesting is we found out that there's actually some Polish blood in our family, which we weren't aware of, and my name has Polish roots, so we're not entirely sure if that was a subconscious thing, but anyway, so that's where I come from. I've lived on the west coast of BC for about 12 years now, in Victoria for the last year and a half, and it's sort of a path back to the west coast for me. I was born in Prince George, moved up to north of the Arctic Circle when I was 6 days old, so that's a photo of me on my mom's back. Lived in England, moved to rural Saskatchewan and then Saskatoon on to Ottawa, and then moved to Vancouver about 12 years ago, and recently moved to Victoria with my family, so that's on Salt Spring Island. And public health is in my genes, as well as social policy as well. So my paternal grandfather was a public health inspector in England, and although that public health notice is a little bit predates him, I thought it was an interesting find on the internet. This is my grandparents and my dad and his sister. And then my dad's a public health physician, and the significance of the photo on the right, pointer, is a photo of the Saskatoon Health Unit, I guess in the 80s, during a salmonella outbreak that was linked to eggs. So the big billboard looking over the Saskatoon Public Health Unit says, "Eggs light up summer," like a big advertisement for eggs. So I had to figure out why that was amusing. And then, yes, linked to my mom's involvement in human rights and indigenous law. So how did this affect my career path in public health? I think as I got older, I learned to see what the role of public health professionals was in some high-profile events. So the E. coli crisis in Walkerton, enactment of smoking bylaws, which were quite controversial at one point in time, and then public health response after natural disasters such as tsunamis. This is actually a photo that my dad took in Indonesia. And then things like restriction on tanning beds, for example. And then I think SARS was sort of the biggest thing that happened right around the time that I embarked on a career in public health. So my early start, I worked in a lab during my undergrad, actually helping to support outbreak investigation for a salmonella outbreak that was linked to Lunchables. And I found that a very valuable experience in that I realized I didn't want to work in a lab. So then I was lucky enough through that job to get a contact with City of Ottawa Public Health and spent a few summers doing West Nile surveillance, which was basically picking up dead crows, and wearing these super sexy hip waders and doing water sampling in the Ottawa and Rideau rivers. So through the contacts that I gained there, people said, well, have you thought about epidemiology? And I was like, not really. I don't necessarily really know what that is. So I started looking into things and then putting pieces together and thought, oh, that actually interests me. I have an interest in math and sciences and statistics, and this might be a good way to sort of combine things. So the stars aligned, and I was able to go to the UK for a year and a bit and did my master's in epidemiology at the London School of Hygiene, Tropical Medicine, so the birthplace of modern epidemiology, so John Snow. And John Snow pub with a pump handle, and the iconic pump handle in the front was somewhere we frequented quite a bit as our class there. So based on that experience and what was going on in that school and the amazing work that they do, I really wanted to be, or I thought I really wanted to be like Kate Winslet from Contagion. I wanted to be a disease detective and investigate these high-profile communicable disease outbreaks. So I did that for a little bit. So I was lucky enough to be accepted into the Canadian Field Epidemiology Program, which is something I would love to talk to any of you about at any time, so feel free to ask me questions. And I was placed for 2 years within the Public Health Surveillance Unit at Vancouver Coastal Health Authority. So during that time, most of what I did focused around public health surveillance and outbreak investigation. In particular, outbreak of invasive group A strep, which was actually not in BC, was happening in Thunder Bay, Ontario, so I was deployed at the time. And then a number of enteric disease outbreaks, so things like Shigella and Salmonella, E. coli, and whatnot. So it was through that work that I learned really some of what the core functions with respect to data and analytics are that support public and population health. So those are public health surveillance, so the day-to-day data collection, communicable disease, opioid overdoses, injuries, et cetera. And then epidemiological investigations that result from that if there are increases, clusters, outbreaks seen. And then population health assessment, so looking at the health status of the population as well as some of the risk and protective factors for chronic disease and injury, mental health, and whatnot, as well as the critical piece around knowledge transfer. So I just put this asterisk just because where that function sits within BC is called different things in different health authorities and provincially. So public health surveillance unit, epidemiology and surveillance unit, population support unit, population health observatories, and my team has the long title of the Population Health Assessment, Surveillance, and Epidemiology team because it has a nice acronym of PHASE, although it's not really a phase, but we're here to stay. So after my field epi experience, I spent some time working with the First Nations Health Authority, and that's where I was sort of exposed to the First Nations perspective on wellness, which is really a holistic model with the individual in the center and all the aspects that influence health and wellness and the social and structural pieces related to that. And my work at the FNHA was involved sort of trying to lay out a framework for public health surveillance as it relates to First Nations communities and First Nations Health Authority as a sort of provincial/regional organization. So I spent a lot of time thinking about this and it really struck me that it would be great if we could apply this holistic model more broadly to our healthcare system overall. And so that just changed my perspective on, I think, everything, but also the importance of the types of information we need, who needs those types of information to do their work, and how we can influence change. So fortuitously, I actually ended up going back to Vancouver Coastal Health because there was an opportunity that arose to work on their My Health, My Community survey. So that for me was an opportunity to sort of take a step back and see the big picture and look at all the types, the determinants of health and the society structural health system factors that influence health and wellness at the individual and community level. So I think Christina showed this yesterday, and I'm sure people are familiar with it. So 60% of the factors that influence health and wellness of population, Canadians specifically in this instance, are related to factors, lifestyle, environment, sort of socioeconomic determinants of health, and the remaining 40% with respect to healthcare and biological factors, although that's where the disproportionate amount of money goes to, is to our healthcare system. And this slide just sort of reiterates the fact that in 2017, the top 10 risk factors contributing to death and disability were related to behavioral and metabolic, so related to diet risk factors, and then some environmental factors. So, and as we all know, and these are just some results from Vancouver Coastal Health and Fraser Health My Health, My Community survey, there's inequities with respect to access to healthy diet, with respect to food security, and healthy behaviors like tobacco and alcohol consumption. So what are some of the data sources that we need to tap into to try to look at some of these determinants of health and start to assess population health and assess risk and protective factors? So the census is sort of our primary source of information with respect to social determinants of health. And thank goodness for the reinstatement of the long-form census in 2016, because there was definitely a gap in 2011 when that was not a mandatory requirement. I think people are still catching up in terms of some of the knowledge at the community level and specific subpopulations. We rely on things like the homeless count to get an accurate account of the number of homeless individuals on the streets at sort of a point in time in our urban areas. There's a lot to be gleaned from administrative data. It's not necessarily always as accessible as we might like it to be, so I don't know if it's necessarily mined to its full extent yet, but that's something that at least my team is working on. And those administrative data, so looking at healthcare encounters for specific conditions or whatnot, are then linkable to things like census, so we can get an idea of the distribution of social determinants of health within different health outcome subgroups. And then we rely a lot on population-based surveys. So those could be geographically based for a specific population, or demographic based, or a lot of school-based surveys as well. So those would be things like the Canadian Community Health Survey, the General Population Survey, tobacco surveys, et cetera, as well as things like the Student Learning Survey, the Adolescent Health Survey. I could go on. So in BC, the Ministry of Health uses this health system matrix to define different segments of the population that are using or accessing healthcare. So starting on sort of the top left with the non-users, working through the end to end of life. And these are mutually exclusive categories based on, if you have sort of indicators that would put you in more than one category, you're put in the category of sort of highest complexity. And then this image just shows sort of the distribution, based on a slightly different measure, but of those types of users within the health system. So the majority at the bottom, either health system non-users, health system users with no health conditions, minor chronic conditions, or minor acute conditions, so injuries or whatnot. And part of our aim, I think, with population public health is really to look at those who are either non-users or healthy users and figure out how we can keep them healthy. and keep them out of the healthcare system, because one of the issues being that our healthcare system is not sustainable in sort of the current path that we're on in terms of the need for resources at the major acute and the major chronic end of things. So the more that we can keep those at the base healthy, then the less burden on our healthcare system overall. So wanted to switch gears for a second and just talk a little bit about the role of the medical health officer. Because I think generally people might know what medical health officers are, but I think it's always a good reminder around the legislative responsibility that these positions hold. And in particular, so my role as the manager of population health assessment, surveillance, and epidemiology, and team of epidemiologists and analysts report directly to the Office of the Chief Medical Health Officer. So we provide the data to support the legislated responsibilities of medical health officers under the Public Health Act. So to read all of this, but just wanted to point out a few key terms. So they have statutory responsibility for carrying out legislative requirements under the Public Health Act, the Community Care and Assisted Living Act, Drinking Water Protection Act, and school acts, as well as other acts and related regulations. They're involved in directing public health response to local public health threats, so communicable disease, public health emergencies, et cetera. They're responsible for advising on reporting out on these issues, and also an annual reporting component on the health of their population. So that's overall, but then they can have specific responsibility for specific geographic areas, like we have on the island. So we have one medical health officer for North Island, 2 for Central Island, 1 in Cowichan Valley, and 1 for the rest of Central Island, and then 2 in South Island, and then our Chief Medical Health Officer. So they have geographic and then topic-based responsibility. So they're also responsible for working with other public health professionals and providing direction to these through whatever structure is in place within the health authority. They provide community medicine sort of consultancy, so they provide evidence-based opinions to various stakeholders, and then they work collaboratively with health authority boards and other agencies and other boards to assist in resolving or anticipating health-related problems. They have a responsibility for monitoring and assessing the health status of their communities and making recommendations for strategies to address health issues, including implementing immediate public health actions. So I think the delegated responsibility under the public health emergency that was declared in April 2016 for the overdose crisis, the delegated responsibility from the provincial health officer to the medical health officers sort of can be reflected in this. And then they have the responsibility or delegate the responsibility for collection of data and statistics over a broad range of health and health-related issues, looking at trends and analyzing problems, et cetera. They also have a role in community health planning, evaluation, research, and program development, and a role in advocacy, so a bit of sort of an arm's length responsibility sort of from the government side of healthcare. So engagement is critical. It was 5 slides of all the roles and responsibilities that medical health officers have legislated to them. They can't do it on their own. They rely heavily on engagement with, or in collaboration, cooperation with internal partners, so both within public health, so public health nursing, dietitians, speech language pathologists, et cetera, as well as environmental health staff, so environmental health officers, drinking water officers, healthy built environment consultants. And then externally, so I think this is where the population health assessment data and bringing all these pieces together really becomes the most critical, that we rely so heavily on our external partners because they are the ones that can do most of the work. So health and social service providers, local government, staff and politicians, so that would be municipal government, regional districts, First Nations communities, as well as community organizations and networks. So we have our network of, or our set of community health networks on the island, which were key partners for knowledge transfer, knowledge exchange, as well as advocacy groups and pretty critically our academic partners. So I just wanted to, okay. The clock was working yesterday. I'm good. So I just wanted to present a few examples. I will preface this by saying most of these are not local to Vancouver Island examples, partially because the work that I was most heavily involved in terms of being able to gather, analyze, and produce health intelligence was at Vancouver Coastal, and we're moving towards trying to implement or get similar work off the ground on the island as well. But I'll also say some of the infographics, because Charlotte gave a shout out to her husband yesterday, some of the infographics were actually done by my husband, so I also like to present those. He has nothing to do with public health, but he's a graphic designer, so anyway. It gives me an excuse not to present graphs. I can do something that's a bit prettier. So in terms of tools that we have, I guess, available to us or that we produce that gives sort of summary of population health assessment and risk and protective factors. We produce a set of local health area profiles on an annual basis, which are basically our most granular sort of community level tool that we have at this point in time, although with the development of the new community health service areas, we will be looking to produce data at smaller granular or smaller community level as well. And then we also rely heavily on inputting in and also sharing the wealth of resources that the Provincial Health Services Authority and their population public health team and the Provincial Observatory has put together in terms of community health data website, community profiles, and some dashboards that pull together chronic disease information, and that's evolving over time, so there'll be even more available in coming years. So incorporating health into local planning. So if we produce these types of reports or dashboards or infographics, whatever, how do these data actually get incorporated into local planning from a health perspective and ultimately influence the health of the population? So some examples are strategies and visions. So from a Lower Mainland example, the City of Vancouver's Healthy City Strategy incorporates a number of indicators around health, which were pulled from data that the Health Authority was able to provide and then will monitor over time. Official community plans. So our regional built environment consultant, J.J. Hia at Island Health, receives referral requests from communities to provide a health lens on their official community plans. So any data that we have at the community level to support different areas within those community plans will be incorporated or will be provided, hopefully incorporated. Use data to inform transportation planning. I have an example to share. Community charters such as food security, child and senior-friendly communities, et cetera. Influence policy and bylaw. So, for example, policy around alcohol sales or restricting alcohol sales or not, as the case may be. And then data to support climate change, adaptation planning, mitigation, et cetera, at the community level, which Matthew spoke about yesterday. The Healthy Built Environment Linkages Toolkit is a valuable resource which supports health professionals and local governments in their partnership in terms of figuring out where to apply the data and information around all these different areas. So we have data to support that, and this toolkit sort of provides a framework for how to categorize things, and encourage you to check that out. So I mentioned transportation planning. So in 2015, there was a transportation and transit referendum or plebiscite in Metro Vancouver, where individuals were asked if they support a 0.5% sales tax to be added to be dedicated to transportation improvements in the region. Ultimately, the answer was no, but the Vancouver Coastal Health and Fraser Health did put together a lot of information that supported some of the health arguments for why investing in public transit and transportation infrastructure would be important from a public health perspective and a health equity perspective. So this infographic just sort of highlights who are the biggest sort of transit users. So highest transit use in low-income households, highest among those with multiple chronic conditions, highest among 18 to 29-year-olds, so youth and students, highest among recent immigrants, and lower among parents with young children, so may relate to accessibility issues, and then higher among visible minorities. So make the extension that investing in transit and increasing transit infrastructure would benefit some of the more vulnerable population. And just some results here that show the link between using active modes of transportation, so that's a combination of transit or biking and walking, decreases the odds of being overweight or obese. So that's actually decreases the odds by 22% for those transit users, and 48% for those biking and walking. So some benefits are walking to the bus or SkyTrain or whatnot. And also their analysis showed that if you spend less time commuting in your car, then you spend more time in your community. And so those with a commute time of more than 50 minutes had a 56% less, were 56% less likely to experience a strong sense of community belonging compared to those who had a commute time of less than 10 minutes. So the data can also be used to influence neighborhood design. So this map shows the distribution of walk scores. So this is the same information that realtors use to define sort of the walkability, likability, et cetera, of real estate property. So this map shows the distribution. The orange is those areas that are more car dependent. The yellow are areas that are somewhat walkable, and the green areas, so you can really only see in the concentration of downtown Vancouver, are those that are defined as a walker's paradise, which I believe is a walk score of 90 or more. And so what? Well, they were able to show that that the risks or the odds of being obese or overweight, and this is self-reported height and weight from a survey, but adjusted to account for underreporting of weight and overreporting of height, showed that it's a thing. Statistics Canada methodology showed that those who lived in Walker's Paradise had an odds ratio of 0.69 of being overweight or obese as compared to those in car-dependent neighborhoods, and you can see the distribution there. So access to healthy foods. So this has implications for things like permits for new development and grocery stores and that type of thing. So this was pulling some My Health, My Community data for the city of Richmond specifically, in conjunction with some of the administrative data that the environmental health officers have in their database. So looking at categorizing all licensed food outlets into healthier and less healthy. And you can see the distribution across the city of Richmond. And then looking at that in relation to consumption of healthy foods or fruits and vegetables. So there was both a relationship with respect to density of food outlets and then with respect to distance from food outlets. So people living in neighborhoods with a high density of less healthy food retail were 70% more likely to consume fast food 2 or more times a week. And they were 2.2 times more likely to consume sugary beverages 3 or more times a week. And that's compared to people who living in neighborhoods with no less healthy food retail. And then people living in neighborhoods with a high density of limited service food retail, so fast food type restaurants, were 74% more likely to consume sugary beverages and 40% more likely to consume sugary snacks multiple times per week compared to those who were not living in neighborhoods. So accessibility and density plays a role in terms of choices and whatnot. And then similar results with respect to distance. Point out, for every 1 kilometer away that people live from a fast food retail outlet, they're 32% more likely to eat 5 or more servings of fruits and vegetables a day. So what about social connectedness? So sense of community belonging and sense of social connectedness has an impact on self-reported and also diagnosed sort of health outcomes. So the map on the left shows a distribution of sense of community belonging across the Metro Vancouver and Fraser Valley region. So the darker blue is those that have a higher than average or a higher than average proportion of those who have a very or somewhat strong sense of community belonging, and the lighter blue is those who have those areas that have a lower than average sense of community belonging. And then on the right side, you can see the distribution of those reporting a strong social connection with age. So those, so there's an increase with age with respect to sense of community belonging, so it gets better as you age, but not really that same trend in terms of number of people to confide in. So that has implications for, programs and services and whatnot. So like you said, people who feel better socially connected also have better self-reported health and better self-reported mental health as well. So I use a lot of examples from my health, my community, and there's a lot more that I could talk about. Some of those visuals lend themselves better to to discussion. But I also wanted to point out from the 2018 release of the Adolescent Health Survey from the McCurry Center Society, one of the things people are paying particular attention to is the large proportion of youth who have indicated that they have been vaping, either with or without nicotine, in the past month. And so that's something that on the island, 25% of those youth who were surveyed reported that they had vaped with nicotine in the past month. So obviously that has big implications for policy, for engagement with schools and school districts to try to counteract what's going on. So the title was a population health assessment. What does data have to do with it? In my opinion, data has everything to do with it. Population health intelligence, so the gathering of all of these types of information on population health assessment, risk and protective factors, really provides information for action, and that action can be public health interventions, health promotion and advocacy, program planning, monitoring and evaluation, and information to support grant funding and proposals, as well as to influence policy decisions. So for example, on alcohol, tobacco, which can have huge population health impacts. the caveat being that producers of this intelligence need to have good data and analytical tools, and this needs to be well-resourced. So just sort of summarize some of the key considerations in looking at what data are available to inform some of these data needs. The level of granularity needs to be such that it's either at the community level or at the level of the population for which the end user is able to use for their purposes. Needs to take into consideration urbanality and rurality. An example I'd like to give, this sort of context, one of the questions on the My Health, My Community survey was, do you feel safe walking in your neighborhood alone after dark? And those without asking for any context, those in rural areas said no because of animals, bears and whatnot. And those in urban areas were more likely to say no if there were, if there's an increased instance of crime or whatnot in their neighborhood. So, really needing to take into account that context. Needing to make sure that your data are representative of your population. So by age, gender, ethnicity, income, et cetera, social determinants of health. That your data is available at a frequency that you are able to assess change over time and assess, evaluate guidelines or evaluate interventions in a timely fashion. The right questions need to be asked. And part of that is proper engagement. So, nothing about us without us. So from the community perspective, First Nations and other communities, really making sure that if you're doing primary data collection, so surveys or focus groups or whatnot, that proper engagement happens. And then obviously that feeds into asking the right questions. And then also making sure that effective knowledge translation happens. So I didn't really talk about, the knowledge translation component or how the data are analyzed or presented, but obviously that's a huge focus of the work that we do in terms of trying to get information out in a way that people can relate to and is useful. So it's taken me quite a while one of my former bosses always used this quote. And I always liked it, but it took me a while to figure out exactly what it meant. And now that I know and understand what it means to me, and I guess there's some debates, but I feel comfortable using it myself. And it's, if you don't know where you're going, any road will get you there. So if you don't know where your starting point is, and you don't know, you don't have a good understanding of, your population health assessment and whatnot, and you don't have an end goal, then, you can get there however you want. You won't necessarily be able to measure any outcomes or prove that, anything that you did actually made a difference. But if you're purposeful and, you have a good evidence-based starting point for making decisions, implementing programs, informing policy, whatnot, and know what your endpoint is, then you can see that road to get there and hopefully demonstrate success along the way. I think that's it, yes. So. Thank you, everyone, for your attention.
Whoa, that's loud. Now it's time for questions. I'm sure there are many. That was amazing. You covered a lot of ground. I'm doing my scan. Well, okay.
I don't have a lot of experience with data or using data software, but I really like it. So do you have any advice for how to get into epidemiology if you don't really have that science or math background?
Yeah, I think part of it depends on the context in which you're working. If you're able to end up in a position where you're able to develop those skills as part of your, day-to-day work, then that's fabulous. Or if you're working in an environment where you do have access to statisticians or epidemiologists or whatnot, then, look to them for mentorship. But also, academic partners and take the opportunity to consult with your peers and supervisors or whatnot. But then there's a wealth of online courses that you can take. Part of the issue is that, it's good to be in a position where you have some data to work with so that you know what you want to do with it. A lot of the online courses tend to be theoretical and whatnot. So I would say a combination of things. Yeah.
So we do, at the graduate level, we do have both an epidemiology and a biostatistics course, which the MBA, well, there you go. So that got you started. I think, yeah, it's a matter of seeking out the kind of material that you're interested in. And, Karen or Nate or any of us really could give you advice about, what other courses you might look for if you're interested in a particular area. Other questions?
One of the things that you talked about in your presentation was database linkages. So the idea of accessing, I'm assuming health data from average people. And I just think that that's an interesting field of study. You can obviously learn a lot from that, from linking census data to health data. But what about privacy ethics and confidentiality and issues like that? Do you have any insights on that as a field or just general thoughts on privacy and ethics around databases?
Yeah, great question. So, I guess referring to our administrative data that we would have within the Ministry of Health, and then, linking that potentially to, so those data would be provided to the health authorities under a particular information sharing agreement that would stipulate what we're able to do with it. And so as long as those guidelines are followed and we're respecting that, then that should cover off on, those are legal frameworks and things that should cover off on protecting privacy. But anything that sort of goes above and beyond the intended uses would have to go through either a quality review or an ethics review to determine whether or not those safeguards are in place. For the most part, we aggregate the data to a level where you're not identifying individuals. So in terms of releasing information at the local health area level, for example, there's no real risk of re-identification. But it's definitely something we've grappled with quite a lot in the context of the overdose crisis, because we're dealing with small numbers of individuals who have died in small communities. And we need to get the information out there, but we also need to be very cognizant of, the context in which that information is getting out there. So it's, it's not black and white.
Thank you for your presentation. I was just curious, you provided a lot of examples and you said that you could talk about a lot of different examples, but I was curious with just the recent legislation around cannabis and the Canada Food Guide changes, is there anything in the works for those two areas and what questions you'll be looking for and how you're going to address those, if you have any insight on that?
Yeah, that's a really great question. There are, at the provincial level, surveys that capture so cannabis utilization, for example, and patterns. So, I heard on the radio on the way here today that Statistics Canada had just released some results. So I'm hoping that we have some provincial data soon. And same with the Canadian Community Health Survey, which asks questions around consumption of fruits and vegetables and whatnot. That's fine at the provincial level, and we do get data down to the health authority level, the health service delivery area level, so we do have some data to look at trends over time and the impacts of the introduction of legislation and changes to food guide or whatnot. But currently on the island and on health authorities outside of the lower mainland, we don't have access to that information consistently at a granular enough level to see what the impacts would be in individual communities or neighborhoods or specific demographics. So.
Hi, thank you. That was a really interesting presentation. I'm curious, you mentioned the transit example in Vancouver and the vote for a tax increase to improve that system. And it seems to me that there's a tension between the knowledge and sort of the data and that expert perspective versus public awareness and public and political will to enact changes based on that data and the predictions from it. So I'm just sort of curious if you have any comments or ideas on how to address that. Like who addresses the sort of public or political will aspect of acting on data, as well as, is it just about education, or like smoking seemed to be addressed through a combination of education and legislation? So just curious about your thoughts on that balance and how it's achieved.
Yeah, that's a really good question and not an easy answer. I mean, I think in terms of the responsibility to, engage with the politicians and to provide some of that advocacy and that sort of evidence, I mean, that does come under the role of the medical health officers. I think part of the issue is that like return on investment and the social return on investment, and being able to actually show what these investments now will have, like what for those who hold the purse strings, like the implications are of acting or not acting. And so going back to Christina's presentation yesterday around the predictive modeling, we need to have good data to start with to be able to make those predictions and to be able to come up with something that does speak to those people that are dealing with, deficits and decreasing budgets and whatnot. And those are the people that we're asking to, take money out of a limited resources to do something that they're not necessarily going to see the change from in their political term or, necessarily even in their lifetime. So, yeah, so in terms of education and enforcement and legislation, I mean, I think it's a combination of things. It's multifaceted. I think immunization is a good example of that, where, it depends. It depends who you're talking to. It depends who you're targeting your messaging at. It depends on what their context is. And so, yeah, it's all of the above.
Elle, did you have a question?
Hi, thanks for your presentation. I used My Health, My Community, the data from it, for one of my projects this semester. And I was wondering, it was great. I loved it. It was fantastic. I'm a nerd for infographics, so it's great. I have two questions. One, are you guys going to repeat that in the Vancouver Coastal and Fraser Health Authority regions? And then also, are you guys going to replicate that in other health authority? Because I really wanted to apply that database to the other ones that I was doing. I was like, darn it, it's not there for Revelstoke, and I really would love it for Revelstoke. You know what I mean?
Yeah. So yes, I can't speak for we anymore as Vancouver Coastal, but yes, they are looking to replicate, just trying to jump through a few hoops to get things finalized, but the hope was to replicate in 2019, so it would be a 5-year gap. So Island is actually partnering with Interior Health Authority and Northern Health Authority to look at a feasibility study of doing something similar across our 3 health authorities. So there are, some interesting differences and interesting similarities. The population is more distributed, the more rural population, so there are specific geographic considerations that need to be taken into account, as well as political will and whatnot. But yes, we know that we need the data, and we do look to our colleagues in Lower Mainland to help sort of support us. And so, yeah, fingers crossed.
Is there someone else in this row who had a question? No? Oh, next questions. Okay, back up I go.
Thank you for your presentation. Going back to the My Health, My Community survey, I'm just wondering how you come up with some of your indicators. So, for example, social connectedness. How do you come up with those indicators so that they're representative of all populations, whether it's a rural or urban context?
Yeah. That's a good question. So, I mean, first of all, it's not perfect. They might not necessarily be specific to individual contexts, but there is a goal to be able to compare across and within communities, so there is sort of a degree of consistency that needs to be applied. But the core survey questions came up with by reviewing things like Canadian Community Health Survey and other population-based health surveys, and in particular in areas where there would be a need to put first of all, where there might be comparable data, so to keep the questions the same, but also put in context of provincial and national numbers. So that led to sort of specific consistency with respect to some of those questions. So there's the core questions, and then those are under, the buckets that I'm not going to get this all right, but like health status, lifestyle behavior, healthy built environment, health service utilization and whatnot. So within sort of those buckets of the general areas that influence health and wellness, there's sort of some core questions. And then there was consultation done with specific communities or specific groups to determine whether or not there could be some tailoring, either tailoring of specific questions or ask additional questions that were specific to a community context, to the extent possible. It's a really long survey. I think there were 82 questions. I'm not sure how many questions they have on their next round of survey, but we also want people to get to the end. So it's a balance. I mean, things like the rapid risk factor surveillance system in Ontario will ask like a smaller subset of questions on a rolling basis. And so there are other methods to do it where it's not all in one, but that's the method that they chose for My Health, My Community.
Maybe while people are thinking, I'll ask one. So I want to thank you first for being so gracious in linking your talk back to Charlotte's in a way, and reinforcing the public health competencies, which is important. But I guess the question then is, you made an intriguing statement when you were talking, and sorry, this is, I'm an academic, I can't help it, so here comes the theory question, right? Clearly, the modeling that you're doing is framed with the bioeco-social, social determinants of health sort of underpinnings. And you indicated that, during your time at First Nations Health Authority, you really kind of got inspired by Indigenous models of health and well-being. And so I'm wondering how you're incorporating some of those ways of understanding health and well-being into the work that you're doing, or what you might like to do in order to develop models that integrate Indigenous ways of understanding health and well-being.
Yeah. It's a really good question, and it's, I think it's tough. I think it's a balance, because, I mean, part of it is the data, needing data that reflect the system that we're working with and that speaks to decision makers within our system and those who, have the money or whatnot. But then also being able to do adequate and appropriate engagement with communities, or sort of by extension with communities through our partners. So I think sort of like an interim conclusion that I've come to is just really understanding what the structures are and who we need to consult with. So who the organizations are, who internally within our organization has the links to those, external partners who, I want to say represent, but to, engage with their First Nations communities, or who, engage with First Nations leadership, or, other communities, for example. And really making sure that we have a good sense of not missing out, any sort of appropriate levels of engagement. But at the end of the day, it's not going to be perfect. And I mean, I think, I appreciated that Charlotte mentioned, the fact that OCAP cannot be applied in all circumstances. And, when you're talking about primary data collection, obviously that is a key consideration. And I, would look to my colleagues at VStage, because I know that that's something that they have worked on extensively between their first round and the planning for their second round of My Health, My Community is their First Nations engagement. But it's looking at whether or not, we're respecting the principles and making sure that, adequate safeguards have put in place so that we're not doing any harm. So, yeah.
Yeah, it's a long-term endeavor. Yeah, definitely. Anyway, thank you. That was great. Any other questions? All right. If not, wow, perfect group. We are at time. And Marisha, that was amazing. Thank you again. And